foremost, I'd like to acknowledge that we are gathered here this evening on unceded Coast Salish territories. My name is Shelley Tognazzini. I am the Treatment Health and Wellness Coordinator for Positive Living BC, and I'll be your host for this evening. First off, I'd like to thank our pharmaceutical sponsors, AbbVie, Bristol Myers Squibb, Gilead, Janssen, Merck, and ViiV, who make our community forums possible. Oh! Yeah. Okay, I'm a little relaxed now. So the bathrooms. Paul Kirsten said that I could do like an airline thing. So they're out here to the left. I'm not sure that, I almost think that's patronizing, but anyways, the bathrooms are outside to the left, down the hall. And this evening we are absolutely delighted to announce that we have, our broadcast this evening is going out live on a webinar. So we are reaching HIV members and friends across British Columbia. So we'd like to welcome all of those who are joining us online at this moment. It's a milestone and truly exciting to have all of those rural people that couldn't attend this evening here tonight with us via webinar. So that's really great. In addition, we will, as usual, this event be recording. So that camera that is pointing primarily and exactly at the presenters will not reveal anyone in the audience for confidentiality purposes. So, but we are recording as well. We'd appreciate it if you take the time to turn off or turn down your cell phones. Also, we are going to be doing Q&A after the presentation. So both speakers will speak, and then we'll do a question and answer period. Both of these brilliant presenters this evening are very articulate and good on staying on time. So I think we'll have some extra time for a change to have some Q&A. So save your questions until the end. At this time, please allow me to introduce our first fabulous speaker. Natasha Press works as an infectious disease physician at St. Paul's Hospital. She graduated from the University of Toronto Medical School in 1995 and completed her residency training in internal medicine and infectious diseases at the University of British Columbia. Following that, she did a research fellowship in HIV clinical trials with the Canadian HIV Trials Network. She is the program director of UBC's Infectious Diseases Training Program and currently runs the Anal Dysplasia Clinic at St. Paul's Hospital. Ladies and gentlemen, please give a warm welcome to Dr. Natasha Press.
So today I'm going to talk about HIV and cancer, and then hopefully in the question and answer period we can really get into more details about some of the issues that I'm going to raise. So I really want to go through three objectives. The first is just to look at common cancers that we're all at risk for, and then to look at specific cancers that are related to HIV and prevention and screening. So first of all, in general, cancer is very common. 2 out of 5 Canadians are going to get cancer, and 1/4 of Canadians are going to die of cancer. And in fact, in the HIV community, those numbers were a lot less, and they've now just started to catch up to the general population because of the antiretroviral era and people living longer. So these are the most common cancers in Canada. So breast cancer for women, prostate cancer for men, lung cancer, and colorectal cancer. And for breast cancer, there is a 1 in 9 lifetime risk. So what that means for women is that if you're sitting around with your 90-year-old friends, and there's 9 of you, 1 of you will have had breast cancer. So this is throughout your whole life that's your risk. And because it's such a common cancer, there is screening mammography. So that's for women from the ages of 50 to 74, and it's supposed to happen every 2 years. And that's for people who just have regular, no special risk factors. So basically, the screening mammography is something that women themselves can set up an appointment for. Go for your appointment. They squish your breast flat as a pancake in one of these machines and take pictures and look for cancers. Now, for men, the most common cancer is actually prostate cancer, and for this there's a 1 in 7 lifetime risk. And so for men over 50, it is recommended that they get a yearly rectal exam. So that means that your family doctor should be examining the prostate gland, which is over here. And the way it's examined is that the doctor inserts, or the healthcare professional inserts their finger into the rectum and examines the wall of the gut right here, and the prostate gland is just underneath it. So in fact, when you do that, you can examine for lumps and bumps or pain and tenderness. There's also a blood test called a PSA, which is also sometimes used for screening. Now, both men and women have a high lifetime risk of lung cancer. So for women, this is 1 in 15, and for men, 1 in 11. And 90% of people who end up developing lung cancer, in fact, are either smokers or ex-smokers or have had a significant exposure to secondhand smoke. So the one thing that I want you to know is that for every year that you quit smoking, your risk decreases. And in fact, if you have quit for 10 years, you've just cut your risk in half. For colorectal cancer, again, it's common for both men and women. There's a 1 in 15 lifetime risk. And there is screening for this as well for 50 to 75-year-olds. And there's different types of screening, but the most common type is something called a FIT test. And this is a test that basically is looking for hidden blood in stool. So what happens is that before colorectal cancer develops, people will often develop little polyps in their guts, in their colon, or in the rectum. And these little polyps bleed, but they don't bleed so that you notice that there's blood in the stool. They bleed just so there's a very small amount of hidden blood, but this test can pick that up. So that in fact, if this test does show hidden blood, then the next step would be to see a gastroenterologist or somebody who does a sigmoidoscopy or colonoscopy, who looks up into the gut with a camera to actually look for these polyps and remove them. So these are the most common cancers that are in Canada. So the next question really becomes, well, does having HIV affect these common cancers? And although the data can sometimes be a little bit different depending on what you look at, really the only one that comes out as being more common in HIV would be lung cancer. And people have said, well, maybe that's because in some HIV positive communities, there's more smokers. And so that might be part of it, but even when smoking is accounted for, there seems to be an increased risk for lung cancer, about a 2 to 3 times increased risk. For breast, prostate, and colorectal, it's probably about the same. And the guidelines for screening from the BC Cancer Agency don't have anything special for HIV positive. So whether you're HIV positive or HIV negative, the screening guidelines for these are the same. Now, the thing that is interesting is that even though the screening guidelines are the same, it seems that screening is actually less frequently done in the HIV positive communities than in the general population. So, you know, when we sort of speculate, well, why is this? Why aren't people who are HIV positive being screened at the same rate as people who are HIV negative? And you know, part of that answer might just be that when you're seeing your doctor, there's a lot to talk about, right? There's like antiretrovirals and bone density and vaccinations and blood pressure and maybe hepatitis for some people. So there's a lot to talk about, and sometimes I think that this general screening for these very common cancers just falls below the radar. So my first message is, don't forget about age-appropriate screening. So if you're a woman and you're 50, you should be getting mammograms. If you're a man and you're 50, you should be getting rectal exams for prostate. And for both, there's screening for colorectal cancer. And then the other piece of this isn't just screening, but also prevention. And in general, for all of these cancers, some or all of these have shown to be beneficial. So regular physical exercise, that's half an hour of physical exercise daily, eating well, increasing vegetable intake, maintaining a healthy weight, not too skinny, not too the other way, decreasing alcohol, and quitting smoking would be the most important prevention steps to take to prevent developing some of these cancers. And then there's things that you can't change. So as we get older, we're more likely to get cancer. A positive family history sometimes means that you have to have more intense screening or start at an earlier age or do it more frequently or do different types of screening. And ethnicity and race actually play a role in some of these cancers as well. So those are the most common cancers in our population. Now I want to move specifically to the HIV positive community. And when doctors talk about cancer in the HIV positive community, we really divide it into two categories. So we talk about AIDS-defining cancers and non-AIDS-defining cancers. So AIDS-defining cancers, this definition or this terminology really started when the CDC, the Center for Disease Control in Atlanta, started to make its definition for what AIDS was when the virus and the disease were first investigated in the 80s. So that's when they said, oh, there's certain infections like PCP or cryptococcal meningitis, which means that somebody has a weakened immune system and has AIDS. And there's also some cancers that we're seeing in such increasing rates in this population that they're AIDS-defining. So, for example, this is a newspaper article from 1981, and you can see there's this strange pneumonia, which ended up being PCP, which ended up becoming an AIDS-defining illness, and then this rare cancer, which actually refers to Kaposi sarcoma, which was 1,000 times more common in the HIV population than in the general population. So there are 3 AIDS-defining cancers: Kaposi sarcoma, non-Hodgkin's lymphoma, which is 70 times more common, and invasive cervical cancer. This is for women, and that's 5 times more common. So this is Kaposi sarcoma. We don't see it that much anymore, so I thought I would show a picture. And you can see these purple spots. That can be on the skin, they can be in the mouth, they can actually go to lymph nodes or other areas of the body as well. And Kaposi sarcoma is associated with a virus. The name of the virus is HHV8, or human herpes virus 8. It's more commonly seen in MSM, men who have sex with men, and Kaposi sarcoma itself is more common at a lower CD4 count. And the most important treatment for Kaposi sarcoma is actually antiretroviral therapy to restore the immune system, so that the immune system itself can fight this Kaposi sarcoma. Chemotherapy is also sometimes needed, particularly if it's widespread or if it's spread beyond the skin. So this is what's happened to Kaposi sarcoma in the antiretroviral era. And this is a really nice graph because you can see that there's been an 80% decrease. So I said we don't see it as much anymore, and we really don't. I mean, with people on effective antiretroviral therapy and immune systems being reconstituted, this is the kind of cancer that has really become much more under control and less frequent. So the second AIDS-defining cancer is non-Hodgkin's lymphoma. And this is a cancer that will often present, somebody might have fevers, really bad sweating at night, losing weight unintentionally. And depending on where the lymphoma is, really will depend where somebody has their symptoms. So if the lymphoma, for example, is in the gut, then somebody might feel bloating or might not be able to go to the bathroom normally or something like that. And again, this one's also more common with a lower CD4 count. So if we look at this graph, you can see that CD4 counts on the bottom here. This is the number of people who had non-Hodgkin's lymphoma in this study. And you can see that in people who had a CD4 count less than 50, the people who were not on HAART, so that's the black bar, had many more of those people had non-Hodgkin's lymphoma than the people who were on antiretrovirals, which is the green bar. So what this is saying is that for people with a very low CD4 count, less than 50, being on antiretrovirals is certainly protective against getting non-Hodgkin's lymphoma. And that relationship really holds until you get to higher sort of normal range CD4 counts of above 350, where you have your immune system working. So the effect of antiretrovirals at that number is not as remarkable. So again, this is the graph of Kaposi sarcoma, and you can see that it's fallen about 80% in the antiretroviral era. And this is the graph of non-Hodgkin's lymphoma, and it's also fallen quite dramatically by about 60%. So not as dramatically as Kaposi sarcoma, but quite dramatically. And the treatment for that is also antiretrovirals are extremely important, plus chemotherapy is required. Now, the third AIDS-defining cancer that I wanted to talk about is cervical cancer. This is a cancer that's in women only. And it's caused by a virus called HPV, or the human papilloma virus. And in this cancer, unlike Kaposi sarcoma and non-Hodgkin's lymphoma, it's less clear what the role of antiretrovirals is. So it's not really clear how being on antiretrovirals has changed the course of this particular cancer. We know that pre-cancer areas are 5 times higher in HIV positive women than in the general population. And the prevention that's used right now are frequent pap tests that women get. And in some circumstances, HPV testing of the cervix is also done. And that's really, so that the pap test and the HPV testing is really done to look for the HPV types that cause cancer. And then the pap tests are really looking for abnormal cells that could lead to cancer, and so that they can be treated before cancer actually develops. So this is a prevention. Okay, so why is there a higher risk for cancer? Why are there these AIDS-defining cancers? And with HIV and lower CD4 cells comes a weakened immune system, and we know that that impedes the body's ability to fight infections. And in fact, a lot of these cancers are either caused by or associated with infections. So Kaposi sarcoma is associated with HHV8, human herpes virus 8. Some types of lymphoma are associated with a virus called EBV, Epstein-Barr virus, which pretty much everybody's been exposed to. And then cervical cancer is caused by human papilloma virus, HPV. Again, very common. Most people have been exposed to it. Okay, so what about the non-AIDS defining cancers? So I said that when the definition of AIDS was first decided by the CDC, they put in those AIDS-defining cancers because they were so much more frequent in the HIV population than the general population. But since then, since we've entered really the antiretroviral era and people are living longer and longer lives and really normal length lives, we've actually seen other cancers emerge in greater numbers in the HIV population than in the general population. So this is actually quite new because it's only really been since people have been living longer that it's been noticed that these cancers are occurring more frequently. So these are some of the non-AIDS defining cancers. So anal cancer, liver cancer, Hodgkin's disease, which is almost like a lymphoma, lung cancer, head and neck cancers, mouth and throat cancers, testicular cancer, melanoma, skin cancers are some of the ones that have been seen in greater numbers. And the interesting thing is that a lot of these, again, are mediated by infections, by viruses. So most of anal cancer is caused by human papilloma virus, which also causes cervical cancer, and smoking is a risk factor for that as well. Liver cancer, a lot of that is caused by hepatitis B virus or hepatitis C virus. Hodgkin's disease is associated with Epstein-Barr virus, which I said pretty much we've all been exposed to. We talked about lung cancer before and smoking as a risk factor. And then head and neck cancers are also, some of them are caused by HPV, and again, smoking is a risk factor. So I wanted to talk a little bit about HPV, human papilloma virus, and it's really a group of viruses. There's 100 different strains, and they don't each have a name, but they each have a number. So there's 100 different strains, each with a number, and about 40 of them are sexually transmitted, and these are really some of the ones that are causing these cancers. So there's really 4 human papillomavirus types that I think are important to remember. HPV 6 and 11 are responsible for warts, and HPV 16 and 18 are the 2 that are responsible for most of the cancer. Not all of it, but most of it. Now, probably everybody had warts as a kid, I'm assuming, I did. But the reason I bring this up is because even though it's the same virus, it's actually different types, right? So this is types 1, 2, 3, 4, and in fact it has nothing to do with anal cancer or cervical cancer. So there's different types of warts, there's different types of HPV, so it can get a little bit confusing, but we're really talking about just the ones that are really below the belt and are very specific numbers. So when we look at HPV-associated cancers, nearly all of cervical cancers are due to HPV, and in fact, most of those are due to HPV 16 and 18. About 85% of anal cancers are due to HPV. There's a lot of other genital cancers that are due to HPV. And then probably about a quarter to a third of head and neck cancers are due to HPV as well. And in fact, in terms of prevention for this, there are 2 vaccines available. So Gardasil is what we call a quadrivalent vaccine because it protects against 4 different types of HPV. So it protects against the 2 main types that cause cancer, 16 and 18, as well as the 2 main types that cause warts in the anal area or the genital area, so 6 and 11. And then Cervarix, we call that a bivalent vaccine because it works against 2 different types, and those are the cancer ones. So it doesn't protect against warts, but it does against cancer. So what do we know about these HPV vaccines in HIV-positive individuals? Well, first of all, let me tell you about HIV-negative individuals. So in HIV-negative men who have sex with men, we know that the quadrivalent vaccine, the one that protects against 4 types, decreases pre-cancer in the anal canal by about 75%. Now in HIV-positive men, we don't have those kinds of studies where they were compared against a placebo to see what happens. So instead, the studies that we have are just giving the vaccine, making sure it's safe, making sure it doesn't cause any strange side effects, doesn't affect the CD4 count or viral load, and then measuring the immune response in the blood. And all those things work in HIV-positive men. So it's safe, it doesn't seem to have any adverse effects on the CD4 count or viral load, it leads to an immune response. So we sort of take a leap of faith that it's going to work the same way as it does in HIV-negative men. Now for women, again, HIV-positive women were not included in the original trials, but for HIV-negative women, we know that the vaccines, both vaccines, are very effective in decreasing cervical cancer, as well as decreasing anal infection with human papillomavirus. And a similar study is now being done in women, and again, it leads to an immune response, and it's safe. So in terms of the HPV vaccine, right now the recommendations in Canada and in British Columbia are that girls and women aged 9 to 45 are eligible for it. Boys and men aged 9 to 26 are eligible for it. That's for the quadrivalent one, the one that has the 4 different strains that it works against. For men who have sex with men, there's no age limit. So any age limit can get it. It does cost a lot of money. It's 3 shots. It's $400 altogether. It's actually free within the school system right now just for girls, but hopefully boys will be brought into that program. And there is some free vaccine available for women less than 26 years old. Some of the HIV clinics have some free vaccine. Some of the youth clinics have some free vaccine as well. So I would recommend that anybody who meets criteria and hasn't been vaccinated should get vaccinated. So the other screening or prevention method for anal cancer is the Anal Dysplasia Clinic, which is at St. Paul's. And this is really a collaboration between St. Paul's, between the Cancer Agency, and between the Center for Excellence and IDC. And basically, this clinic, for the women here, this clinic is analogous to having a pap test done. For the men, I'll explain that. So basically, this clinic is looking for pre-cancer areas so that they can be treated, so that they don't go on to develop into cancer. And if we look at who's really high risk for developing anal cancer, because we're definitely seeing a lot more of it. So who's really high risk for developing that? Well, the highest risk group would be HIV positive men who have sex with men, particularly if we know, or if they know, that they have HPV disease. So whether that's warts, or whether that's a Q-tip test, cytology, that has shown abnormal cells. For HIV positive women, that is also an increased risk compared to HIV negative women. And again, the women who would be at highest risk would be those women who know that they've had HPV in other areas. So again, either warts or an abnormal cervical pap test that has meant that they've had to go to colposcopy. So I'm going to move on to liver cancer, because both hepatitis B and hepatitis C, which are viruses, are risk factors for liver cancer as well. And for hepatitis B, there is a vaccine. So for people who don't have hepatitis B, should definitely be vaccinated so that you don't have the risk of getting it. And in fact, in HIV positive individuals, we double the dose of the vaccine to make sure that it works. So there have been studies that show that doubling the dose increases the chance that it's going to work. So if you are going to a clinic that maybe doesn't have a lot of HIV expertise, just to know that it's double the dose. And for those people who have hepatitis B virus, probably your antiretroviral regimen will either contain Truvada, which is tenofovir and FTC, or some combination of tenofovir with either FTC or 3TC for most people. Because you get a 2-for-1 deal. So those antiretrovirals not only treat HIV, but they actually treat hepatitis B as well. For hepatitis C, there's no vaccine available, but there is lots going on with hepatitis C treatment right now. It's just blossoming, and there's going to be lots and lots of treatments available in the next 10 years. Okay, so what can you do? So definitely for lifestyle, quit smoking, limit alcohol, eat healthy, exercise. For treatments, antiretrovirals are definitely going to be the most important treatment to prevent a lot of these cancers. Hepatitis C treatments, hepatitis B treatment. For vaccines, for people who don't have these diseases, there's a vaccine for human papillomavirus and the hepatitis B vaccine. And then for screening, breast mammograms, anal dysplasia screening, cervical dysplasia screening, rectal exam for prostate cancer, and FIT testing for colorectal cancer. And I just wanted to point out that the BC Cancer Agency, that's their website, has tons of patient information on cancers, on screening, on prevention, and on what's available in BC in different health regions. Thank you.
Thank you so much, Natasha. That was really, it was so lovely to see a PowerPoint used so effectively and so succinctly. Thank you very much. That was great. At this point, again, we'll save our questions. I'd like to introduce our next speaker. Dawn Cloutier is the former Secretary and Treasurer, and recently has been appointed as the current chair of the Board of Directors of Vancouver Island Persons Living with AIDS Society. Dawn has successfully completed all 3 levels of training with the Positive Leadership Development Institute. In addition, Dawn has extensive experience in providing peer support, as well as training in communications, mental health, addictions, and counseling. Dawn is an active, vocal, and experienced public speaker in community, and has even done stand-up comedy on her experience with HIV in Canada and cancer in Canada. Recently, Dawn has been exploring her interest in film editing from Canadian Aboriginal AIDS Network and ICANN Productions. As well, Dawn co-facilitates the Viva Victoria Women's Support Group. I have known Dawn personally for the past 2 years, and have been inspired, in awe, and amazed at her tenacity, integrity, strength, and courage. She is a leader and innovator in community. It is an absolute delight to introduce you to her this evening. Please welcome Dawn Cloutier.
Good evening, everyone. It's great to be here. It's great to be here. I'm a mother of two, a grandmother of 4 girls. I'm a volunteer in the community of Victoria on Vancouver Island. Now basically, Shelley summed it up for me very nicely. I've written an article in the Positive Living magazine when I was diagnosed with cancer, and it was my 7th bout of cancer. And my friend Ramari usually writes Girl Talk, and she was in Scotland at the time and invited me to write the article for her. And I will, you will be given the website to look that up if you like. At the age of 30 was my first bout of cancer, and that was prior to being diagnosed with HIV, Hep B, and Hep C. At the age of 36, in 1994, I was given the rest and my cancer was back. My Hep B is now gone. I've never been sick from my hepatitis C, and my HIV has always been undetectable. Okay, when I was 30, the doctor told me if I was going to have any more children to go ahead and have them right away because he had to do a hysterectomy. I felt I had 2 beautiful girls. I no longer wanted to have a bigger family. I wanted to enjoy what I had. I didn't want to die from the cancer, and I wanted to get it out of my body. So we had the surgery. I've been in recovery for 15 years, and I'm still dealing with cancer. Cancer is like gum stuck on the bottom of my shoe. It doesn't matter what you do, it doesn't come off. When you're told that you have cancer, and this is a patient's perspective, it's worse than being told that you're HIV positive, because there's no pre and post counseling for you. Your family and yourself, the feelings that you go through, the fear, the struggles, it's almost like losing a person in a death. You're mourning, you're grieving, you're separating. It's going through hell, a living hell. The thoughts that go through your mind drive you crazy. And if you allow it, it will. So this is my 7th bout. Yeah, we're going to talk about the pain in my ass. I know this is hard, my family, and I'm a goal setter, and I'm a fighter. I promise my children and my grandchildren that I'm going to watch them, my grandchildren grow up, get married, and have babies. And I do keep my promises, believe me. I need to say that a person with health issues, to begin with, you get to know the signs and symptoms in your body when you're struggling with something. I was up north for many years, and my battles was with the doctors and the ignorance of, or lack of knowledge about HIV. I had to let them know what blood work to do. I had to tell them what tests to run. I had to read my own blood work when the lab results came back. I had to actually educate them, or they didn't want to know anything about it. But I'm still here. I'm healthy, I'm alive. My CD4 count is doing good. Thank you. When I was up north, I helped watch my grandchildren while my daughter went and got her education, went back to school, and she got her nursing career. It's not easy looking after 3 girls, especially teenagers. It was fun, but there was not one uneventful day, I'll tell you. Normally, you would think that your CD4 count would drop just under the stress of daily life, but mine didn't. I was at over 1,200 for quite a few years. I moved to Victoria, and within a 3-month period, I thought when I moved to Victoria, I was going to finally get great doctor care. Okay, I put my hands and my life in my doctor's hands. My CD4 count dropped by half in a 3-month window period. I said my cancer's back, and he said, no. I said, yeah, it is. And he goes, no. He said, relax, you're fine. Your CD4 count's going to drop. You're 20 years HIV positive. I'm going, no. Anyways, I let him talk me into just relaxing and sitting back and waiting and watching. So, I spoke to my friend Ramari and my daughters, and it took Ramari's saying 9 months of her nagging me, seriously nagging me, and getting me to push the doctor to send me into the cancer clinic. And that finally got, after 9 months of a battle, yes, I'm stage 3 end cancer. I've been poked and prodded over the years. Like, nah, I'm not going to say it. Lots of reconstruction, lots of laser surgery, lots of cutting bits and pieces out, repair jobs, okay? Now, I'm on a topical chemo treatment. It's not working. I was put on 7 days, 7-day-a-week treatment. It caused severe chemical burns to my skin. It's like pouring acid on your skin. And yeah, it was painful to sit. When I was taken off the chemo treatment for a month to heal, which I did, and now I'm back to 3-day-a-week. I'm awaiting surgery. I'm being tag teamed by 4 doctors here at St. Paul's. Dr. Applin, Dr. DeGanis, Dr. Raval, and Dr. Hall. Awesome people, I'll tell you. I've had struggles with ministry. I've had struggles. They've refused to pay for my transportation to and from St. Paul's. I don't really even want to touch this topic. Then I was basically told to lay down in the back seat and suck it up. So now I'm waiting for surgery, which is going to happen before September. I saw Dr. Applin in April, and she questioned me as to why my surgery hadn't taken place yet. And I was like, I don't know. And she's going, please go down the hall and find out. So I went, and I had my daughter, and every time I came to St. Paul's, my oldest daughter and granddaughter, 8-month-old granddaughter, came with me. The receptionist came down the hall, wouldn't let me down through the doors, but she came down and met me. And it's unfortunate, but she said, people like you didn't get a window period for surgery. And I'm going, okay, I just had a biopsy. This is running through my head. I just had a biopsy. My daughter's here, my granddaughter's here. I'm going to pick and choose the battles. And that was one I did not want to touch. I have meltdowns after biopsies and laser and cauterization. And I tried to wait until I get home to do that in my own territory when I'm by myself. So I chose not to pick that battle. Now, did she mean people like me because I'm HIV positive, or people like me because I'm out of town? I really honestly don't know. But I'm now guaranteed a spot before September. The staff at The St. Paul's Hospital have been awesome. The doctors have been awesome. Shelley, Hesham, you're always there. You always have a smile on your face. And now, Shelley, you've moved up. Congratulations. The staff and volunteers at Vancouver Island PWA Society are awesome. They ask if I need anything all the time. And they give me quite a bit of support. I'm a mother, a grandmother. I'm a Scorpio. I have lots of fuel in my fire. I'm a volunteer in my community. I'm a woman with rights. I want to be heard. I need to be heard. I want to be loved. I want decent, proper doctors. And that's my right as a human being. But you know, with everything that's going on, I wouldn't change it for a bit, because it's made me who I am today. And it's made it possible for me to be up here today and say this to you. If you feel something's wrong with your body, insist. Push the buttons. Make it happen. Get it checked out. I am stubborn as a mule. Ask my boss. You can ask my kids. Hi, girls. I'm full of life. I love it. I love every minute of it. I FaceTime shop with my grandchildren up north in Victoria. They get to buy what they want. And yeah, my oldest granddaughter is 16 years old. And I have a 13-year-old granddaughter, a 12-year-old granddaughter, and an 8-month-old granddaughter. All girls, we rock. If I had 3 wishes that could be granted, I would ask for no more homelessness, end to poverty, and 50 more years, because you're not getting rid of me yet. Facebook says I'm going to live to 106. What do I want to be when I grow up? I'm going to ask you one question before I leave the podium here, and that's, what made you smile today? I asked myself that question before I got up here. What made me smile today was seeing Shelley, and I had 17 inches cut off my hair last Tuesday, and she said it took 10 years off me. That made me smile. I'm donating my 17 inches of hair to cancer. I would like to thank Positive Living, all the PLDI trainers, Mark, Cap, Dakota. I would like to thank my family. I would like to thank Ramari. I would like to thank Vancouver Island PWA Society. Look out, you guys. This is what you've created. Thank you.
I'd like to ask Natasha and Dawn to come up here. We'll open question and answer now.
Is shingles the same thing as Epstein-Barr? Are they related? No.
You can talk loud.
Yeah.
Whatever you like.
So I didn't know I was allowed to talk without the microphone. No, they're different viruses. They are in the same family, but they're totally different.
Why is there no age limit on the HPV vaccination for specifically MSM? That seems kind of odd, an odd disparity.
So the answer to that is specifically because MSM is a risk factor for anal cancer. And in fact, the vaccine for the general population of boys and men has only actually got its licensing based on the results that it showed for preventing genital warts. So it's sort of, the reason is based on what the trial showed.
I'm curious, I'm 57, okay, I've been HIV positive for 5 years, and the HPV vaccine, how come I'm not entitled to it? Because you would think that being positive, being a woman, that I should be able to get the vaccination.
I'm going to exit the microphone. I think we can hear. Yeah? Can we just speak
Yeah,
up?
I'm pretty good at yelling.
I'm pretty good too.
Okay.
So there have been lots and lots of girls and women involved in the trials for the HPV vaccines. And what we know is that the younger you are, the better your immune response is. So being a 9-year-old, you have a great immune response to that vaccine. And that immune response gets less and less as women get older. So the reason that it's only right now, only women up to the age of 45 are eligible, because really that's the group that's being studied where we know it still works. Should women who are older get it anyway off license? You know, I can't say that it would work, but I don't think it would do any harm.
I don't think so either.
But we just don't know, we just don't have that data. That data is being collected now, but it's just not there yet.
A lot of good it's going to do us over 50 women with HIV that end up getting cervical cancers, you know what I mean? I was just wondering about that, that's all.
Yeah, no, I think there's a lot of people who are using the vaccine off license. So
Yeah.
because it's not what we call a live vaccine, so it's not dangerous in terms of the immune system. So the worst that it would do would be nothing,
Oh, okay.
and put you out $400.
Question back here? Is there a question back here?
Is there a
Yes?
Hep C vaccine?
No.
Giardia, or is that the Gardasil rather? Is there an expiry date for like how often you would get it, or you just get one shot?
It's 3 shots.
And that's good for your life?
That's a great question. The vaccine hasn't been around long enough for us to know.
Okay.
We'll see.
Okay.
So maybe boosters will be required in the future. We don't know that yet.
Okay.
Question here?
Hi. It seems like right from the very beginning, back in the 80s when this all started, or seemed to have started, that there was that definite correlation between the two diseases, cancer and HIV. And then, of course, there were things being said over the decades that we've gone through, where trying to find solutions for HIV was also going to be very good for finding solutions for cancer, because there were certain correlations at that end of it. And one of the things that's been said, that you were saying earlier, was that the drugs that we take to control our HIV are definitely good for sustaining some of the development of cancers within us. But is there still a strong correlation between the two? You know, is there like one bang thing that they're going to find about cancer that's going to be right there kicking the butt of HIV at the same time? Is that idea in when they're doing their research that there's some correlation there? Is there something going on that they're thinking?
So, I mean, that's a great question. So, you know, both HIV affects the immune system and cancer affects the immune system. But really, there's so many parts of the immune system. And even within cancer, even if you just take one type of cancer, like lung cancer, even within that, there's so many different types of cancer. And so I think it's been so hard to put it all in the same basket and find sort of a unifying treatment or a unifying cause. So that hasn't happened. And I think there's a lot of people working on bits, but I don't think it's all come together like that. So for prostate, that's a good question. For prostate cancer specifically, it's so common that a lot of men die with it instead of it. So they die, you know, of something else, and they happen to have a little bit of prostate cancer, which isn't actually sort of doing anything. So a lot of the screening guidelines are really meant to pick up cancer to treat it in a way that it's really going to make an effect.
May I say something? My cancer started before I became HIV positive, and somewhere along the way, I got the HPV virus. And I just was recently told that. I don't know how long it's been in my body. It will always be there. But I honestly don't know how safe these vaccines are for the teenagers.
Thank you.
Yeah, so the HPV virus is the most common sexually transmitted virus. Most sexually active adults will have gotten the HPV virus. I mean, there's, at least 75% of all sexually active adults have been exposed to HPV. And then certainly we know that some communities, for example, men who have sex with men, it can be up to 100% in certain studies. So it's very common. We can all assume that we've all been exposed to the HPV virus. So, the question then really is what happens, right? So we know that the highest rates of HPV are really after people initially become sexually active, so in young people in general, and then they sort of fall over time. So that really does bring up the question, well, are we just controlling the HPV, but it's still hidden within us, because we know that some viruses do that? Or are we actually, is our immune system actually able to clear it after some time, and maybe we're just getting reinfected? And, I think that people are still asking that question. There seems to be more of a thought now that probably some HPV our immune systems are just able to control it. And then if that immunity decreases over time, including with age, that the HPV can sort of come back out.
Question here? Nope, sorry. Question?
Do you think that low-grade inflammation, which happened despite virological suppression, is more of a factor that you're seeing more cancer, especially lung cancer, and people more than the age factor, that we're living longer? It's just more that the low-grade inflammation is still happening despite having, undetected viral.
That could be part of it. I think that a lot of people are just thinking that there's a lot of factors contributing to it. So one of the other factors is that, and this is particularly with the cancers that are caused or associated with viruses, is that by living longer, not just having that chronic inflammation, but by living longer, our bodies have time to sort of get these genetic mutations that then enable us to develop cancer.
Yes, sir.
The only thing I ever heard about HPV was maybe a year or two ago in the States. There seemed to be a lot of controversy about giving young girls the vaccination. Is it because there's something wrong with the vaccination, or?
Yeah, so Don also expressed some concerns about the vaccine. So a lot of the pushback from the States was really about social conservatism and the thought that it would make girls have sex. But there have been some other concerns. So one of them has been about side effects, and the vaccine really, I would say in general, hasn't been shown to have more side effects than, let's say, other vaccines when it's been compared to other vaccines. There's a lot of fainting that happens in young girls when they get it, but it hasn't really been shown to have any long-term side effects. Again, we're talking about a vaccine that we've only had for about a decade, so we'll see what happens. So there is that concern. The other concern, which has come out of Canada, has been that we already have an excellent cervical PAP program, which is supposed to really prevent cervical cancer. Cervical cancer rates in general have been decreasing, and that maybe the vaccine isn't a public health priority because of that. So it's really about a cost-benefit analysis.
Cost-effective.
Yeah.
A question back here, possibly a little off topic, but
Well, I don't think it's off topic. It's
No.
lupus, which is an autoimmune disease also. There's Raynaud's syndrome, and there's a lot of other autoimmune diseases besides HIV. And I'm wondering if, like they're all inflammations, right? If any inflammatory disease that becomes out of control can turn cancerous, right?
So they have actually compared people who are receiving what we call immunomodulators, so medications that change the immune system to control autoimmune diseases. They've looked at those populations as well for some of these cancers, and there are increased risk for some of these cancers within those populations.
So is it all about inflammation, controlling inflammation?
Well, that was the question that was already asked. You know, that might be part of it, but it's not the whole story.
I have a question for Dawn. Yes. I'm just curious because I've had the privilege to walk with you to some degree through some of your journey. What does it feel like now to know what you know and to be in third stage anal cancer and dealing with family and life, and how do you deal with that emotionally?
It's hard. I do have like I said, my meltdowns. A person sheds tears. It's like when 20 years ago when I was told I was HIV positive, the doctor stood in the doorway, the whole lobby in the doctor's office heard him say it. You're HIV positive, you have Hep B, Hep C, and your cancer's back. Okay. I ran out of the office. It's like saying today, okay, your cancer's back. What do? You're crushed, right? I keep it together, I keep strong, I keep looking in the mirror, and I keep putting one foot in front of the other. And, you know, like I said, I've made a promise, and I'm going to keep my promise, come hell or high water.
It just seems amazing to me that we get this one when I was diagnosed positive, that seemed like life-altering, life-shattering, but to have 8 diagnoses, back, after, on top of it, I think that's an amazing courage.
I mean, yeah, it's difficult. It is difficult. And it's, but you have to deal with it if you don't. And if you don't laugh about it or turn it into something better, then how can somebody else learn from this, what I'm having, what I'm dealing with? Like, you know, I could lay down on the floor and die, but I'm not going to. I'm going to fight my way through it. And I'm going to stand on top of the pile. I'm going to come up on top.
Any more questions? Thank you very much, everyone, for being here. Good night. Enjoy the sunset.